So everyone, thank you for joining us from all over the world. This is the second season, third episode of EmPowHER. Special thanks to VLU, the Vein and Lymphatic University, the executive board, for allowing us to put this together and supporting it. I'm joined today, my friends and my colleagues, Ruth Bush, Lina Vargas, Rebeca Reachi, and thank you, ladies, for being here. Dr. Ruth Bush will make some announcements, and then Dr. Vargas will introduce our panelists. Thank you again for everyone for being here.
So thank you, Kathleen, and thank you to our distinguished panelists. I look forward to this webinar. As Dr. Ozsvath said, we are sponsored, and this is the brainchild of Vein and Lymphatic University. Thank you to Dr. Kabnick and Dr. Kanata for this opportunity to showcase these brilliant women from around the world. I have also want to make an announcement that immediately following this, if you want more education, there is an advanced phlebology webinar that is a partnership between the Egyptian African Vein and Lymphatic Society, the Journal of Vascular Surgery, Venous and Lymphatics, and the American Venous Forum. The Zoom link is in the chat. But right now, I want everyone to focus on this fabulous upcoming webinar. Thank you.
All right, good morning, everyone. Thank you so much for being here. For me, it's also such a pleasure and an honor to be able to moderate this important webinar. It is a very, very important topic because treatment of vein disease from a cosmetic standpoint. And today we have two incredible vascular surgeons from Brazil. We're joined by Nara Medeiros. She is originally from Natal, and she's a member of the Brazilian Society of Vascular Surgery. She's a professor of the Federal University in Natal, and she leads the clinic Vascular Angels in the city of Natal. She is a world expert on the CLaCS technique, and she's a fellow of Dr. Kazuo, who created the CLaCS technique. So for us, it was very important to have Nara Medeiros join us today to share her experience and teach us all about the technique. We're also joined by Dr. Solange Evangelista. She is also from Brazil, and her clinic, Varicemed, is in Belo Horizonte. I have not had the pleasure of meeting Nara in person, but I have met Solange, and I know both of you are incredible experts. Solange will be sharing her approach with complete foam for the treatment of vein disease and especially cosmetic treatments. And together, they're going to teach us and share all of the experience. We also want to talk a little bit about differences worldwide and how we set up practices, how we make our practices improve, and how we can change patients' lives through cosmetic treatments. So thank you both for being here. For the sake of time and the fact that we have another webinar following immediately after ours, I'm going to give the word to Nara. She's again going to share about the CLaCS technique. So take it away, Nara.
It's a pleasure to be here. It's a very honor, and I will share my screen to begin the presentation, okay? Thank you for the words. I'm emotional. Yeah. So I am Dr. Nara Medeiros from Natal, Brazil. And today I will talk about what's the real place nowadays for the CLaCS technique. And it's a little about myself. To do CLaCS, when we used to do CLaCS, we cook the vein, okay? Instead of burning it, because if we compare CLaCS with a race car, the most important thing is to do perfect laps rather than faster laps. Today we'll talk about cosmetic results. So we are looking for the perfect turn. So I will talk about how to achieve these results with lower risk. Before I start, I want to remember some issues of the last ESVS guidelines about treatment of varicose veins. And usually this treatment starts with the major incompetent superficial trunks and tributaries and ends with reticular veins and telangiectasias. So to treat telangiectasias, it's necessary to know the vein system. The proposed is cosmetic. And according to the recommendation for patients with reticular veins, sclerotherapy is recommended as the first choice treatment. And for patients with telangiectasias, sclerotherapy would be considered. When we talk about adverse events of sclerotherapy, the guidelines says that is mild, but the most frequent are transient hyperpigmentation, neovascularization and matting, and scars. And when you're talking about C1 patients that want aesthetically results, I think that is not so mild. And Parler and Coles concluded that sclerotherapy and laser may be used in combination for the optimal management of telangiectasia of the lower extremity. And the guidelines bring us the new concept of hybrid techniques. The recent technical modifications have been reported to substantially improve the effectiveness of the transdermal laser. And the objective of hybrid techniques is to achieve effectiveness through the synergy between laser and sclerotherapy. So 1 + 1 will be 3. And CLaCS is a hybrid technique and is described in the last guidelines, was developed by Professor Kazu and consists of the association of Cryo laser with cryosclerotherapy guided by augmented reality. The purpose of CLaCS technique is to achieve efficacy through the synergy between the transdermal laser, injection sclerotherapy, and skin cooling. And the transdermal laser has the ability to perform selective photothermolysis, penetrate the skin without damage and injure the vein. So the guidelines bring that CLaCS is a new option for treating telangiectasias, reticular and feeder veins with promising results, although more studies are required for its validation. But here in Brazil, it's not a promising technique, is a reality. We do this technique a long time, and I have more than 10 years experience of CLaCS. And it's important to know that CLaCS is a method, okay? CLaCS is a synergistic combination for the treatment of varicose veins that combines the proper diagnostic tool, Doppler ultrasound, plus augmented reality, with skin cooling followed by laser and sclerotherapy. And the sequence of CLaCS technique is photo documentation followed by ultrasound detection of feeder vein plus AR evaluation, simultaneous cryo laser treatment guided by AR with followed by cryosclerotherapy guided AR using magnification loops. And the pre-treatment photographic documentation is important because most patients tend to underestimate their own improvement with time. And detailed the photo documentation should be mandatory in superficial varicose vein treatment. Visualization and treatment of feeder veins are key to produce an optimal resolution on telangiectasia. And CLaCS technique follows the principle of prima non nocere, or first do not harm. And while the cost of CLaCS equipment is high, the price of a serious complication on an aesthetic procedure is much higher. The 75% glucose in comparison to detergent agents leads to less anaphylaxis, and is this reason that Professor Kazu used this sclerosant. But the CLaCS technique can do with other sclerosants. This is a paper that Professor published, and he shows that the patients had no allergic reactions, no systemic reactions, no skin burns, no mattings, no infections, and no crushings. So is the reason that he do this technique in his daily practice. And now I will talk about the principles of CLaCS, and I will talk a little about of laser. We know that the skin is a complex organ and deserves our respect. And the main purpose of laser is to treat unwanted injuries without causing damage. The laser action mechanism involves direct physical interactions of electromagnetic waves in human tissue. And this interaction, the light can undergo refraction, reflection, absorption, and dispersion. There are several vascular lesions that can be treated, and there are several parameters and devices that can be used. So how to choose these laser parameters? First, understanding the interaction of the light and tissues to do the selective photothermolysis and getting to know the device. And this is necessary to know these 4 parameters. The first one, the wavelength, is related to the target and where it is. And the spot size is also related to the depth. The pulse duration is related to the size of the target structure, and the fluency is related to the absorption capacity of the target. To choose these parameters, we can answer some questions. The first one is, what will be treated? So this determines the wavelength. How much synergy, how much energy is needed? This determines the fluency. And how big the target? This determines the pulse duration. And how deep? This determines the spot size. So if we will change parameters and need to treat a lesion like this, we have to vary the parameters like we see in, I describe it here. A careful evaluation is necessary to correctly indicate which lesions the laser could target best. There are really regulations that work. That is, knowing then helps in better delivery results. So I will answer now why change parameters to use transdermal laser. To answer this question, I have this algorithm, and in this algorithm, the wavelength is fixed. The pulse duration increases with larger diameters and decreases with small diameters. And spot size increases with greater depth and larger diameters and decreases with the opposite. And the fluence increases with reddish vessels, smaller diameters, greater depth, smaller spot size, and higher pressure. And it decreases with bluish vessels, greater diameters, lower depth, larger spot size, and lower pressure. So here we have a table that was done by Dr. Kikuchi from Brazil. And here he described the variety of the parameters according to the lesions. So if I will change the parameters and I have a lesion like this, I will need to vary the fluency, the pulse duration, and the spot size. But I use CLaCS technique in my daily practice. And in this patient, this is a patient of mine, I use the fluency of 70, the pulse duration of 15 milliseconds, and the spot size of 6. And this is a result all with only one section and after 30 days. So let's go back to the race car, and here we have a car in Interlagos, okay? And if every straightened curve you had to change the shock absorber, it would be unfeasible to complete the lap in a local of this. So therefore, when we fix laser parameters in our machine, we optimize time. This is what the CLaCS provides you. So CLaCS is more than laser with sclerosis. This is videos of mine. And in the first video, I am using the CLaCS technique with glucose. And in the second video, I am using the CLaCS technique with polydocanol. It's important to do minimal twice, use the laser on minimal twice, because we have to change the hemoglobin in meta-hemoglobin. If you can see here, in the first video, I am using the laser very times. And in the second video, I just use the laser 2 times, because in the first video, I will use glucose, and there's a sclerosant with lower potency. And in the second, I am using polidocanol. And in two patients, I use the parameter of 50, 15, 6. And it is really necessary so to change these parameters. Well, in my practice, I fix parameters. In CLaCS, we fix parameters. In CLaCS described by Dr. Kazu, the parameters are fixing because this optimize time. And this is a patient of mine that I did CLaCS with 70 of fluency, pulse duration of 15 milliseconds, and a spot size 6. And the second one is I use the same parameters, and in both I use glucose 75%. This is a patient that I use, I fix the parameter for all lesions, for all reticular and telangiectasias, and I use 50, 15, 6. And I use polidocanol because this patient is a patient that the CLaCS was so painful for her. So I use a low fluency. And this is another patient that I use 50, 15, 6, and polidocanol. And this is results all after 30 days. All patients here, I did only one section and are photos after 30 days, okay? This is another patient, the patient that I showed before, and there's a woman. And I use the same parameters. This is a patient with a matting, and I use 70, 15, 6, and polidocanol. This photo is 30 days after and is only one section. Another patient with different lesions in 1 month, only one section, and the same parameter. Another patient. Here is after, yes, is after 30 days and is after 2 sections. It's only the patient that I do 2 sections in today. And this is a patient, more one patient that I fixed parameters in 70s, 15, 6. To end, I want you to say take-home messages, and it's necessary to not use the laser as monotherapy for varicose veins in the lower limbs. It's possible, but if you use the CLaCS technique, you use the synergism, and this provides better results. I use monotherapy in face, but in lower limbs, I only use CLaCS. In this association with sclerotherapy allows setting parameters, allows the use of the same technique for various types of vascular lesions of different calibers, colors, and depth. And lower fluence is necessary for high Fitzpatrick and tanned skin. Two treat sections with a minimal interval of 3 days are necessary, and knowing the limits of your device is the key to better adapt the parameters to obtain the desired results and to avoid complications. So I think the best technique for the treatment of varicose veins is the one that gives you more confidence in achieving your expected results and the results of your patients with the lowest risk of complications. Thank you so much.
Thank you, Nara, for that amazing presentation. I definitely learned so much, and I cannot wait to be able to ask you a lot of questions that have come to my mind. So let's keep going on. Solange, can you please share your screen? We're super excited about your presentation. In the
While the
meantime,
screen sharing is happening, I just wanted to make sure that we thank our amazing sponsors as well, Boston Scientific and Bard. Thank you so much for the support.
Just
While we're
a-
switching, one other,
Perfect.
I just have a question.
Mine.
Does anyone do this technique here in the United States? Do you know?
I literally was thinking the same thing. I mean, I definitely think it is widespread use everywhere else. I think we are unfortunately a little behind as far as cosmetic sclerotherapy associated with other techniques go. Like I personally definitely use laser on my practice every day, but it's not specifically the CLaCS technique. I do use a 1064 laser, but I do it in a different way. Not necessarily in conjunction and prior to doing sclerotherapy. So those are the kind of variations that we see worldwide that it's worth discussing. But I definitely don't think it is as widespread. I don't know if any of you know of anyone doing CLaCS here in the United States, like the True Technique by Dr. Kazuo.
Well,
What
here in
other-
Mexico, let me tell you that we are trying to do it. So we are very interested to learn about it. So Dr. Solange,
I'm
welcome.
trying to put my presentation.
Do you
While
see
you're
the
doing
share
that, one
button?
other question I have would be, you had mentioned that you do monotherapy on the face. Well, how is the face different from the leg?
I think it's the pressure of the in the vein, you know. In legs we have high pressure in veins, so it's necessary to do more sections. It's possible to do monotherapy, but you have more sections. And when you use the sclerosant, in a potted sclerosant, you can do only one section and bring 80% of the enfim. I can't, and how can I say, a result of 80% of disappear the veins, you know? We expect with one section, the disappearance of 80% of the veins is our expectative when we do in conjunction.
Can you
Thank you,
see my
Clara.
presentation on the screen, please?
Yes.
Okay. Can I begin the presentation, please?
Absolutely, Solange, go ahead.
Okay. I'd like to thank the organizers for the opportunity to share my experience with the product and the patients. 25 years ago, when I, along with others, introduced the sclerotherapy in Brazil, both vascular surgeons and patients approached it with it was not well accepted. However, patients seeking alternatives to surgery allowed me to gradually implement this technique. I don't know what is happening here. I think I need to start again because my slides don't go on.
Are you trying with your keyboard to move forward? Would that work?
It's possible for you to pass the slide? No.
Are you on full screen?
Okay,
Okay. Perfect. There you
that's
go.
okay. Okay, can you see?
Yes.
Okay, excuse me. No disclose. Here are some key considerations for physicians. Regarding safety, use nitrogen-free physiological gases. Why? These foams dissolve more efficiently, minimizing risks. In contrast, atmospheric-based foam contain nitrogen bubbles, which dissolve inefficiently in blood and they are linked to neurological events. Second, mind the bubble size. Approximately 30% of the population has a PA4, allowing large bubbles to bypass the lungs and reach organs like the brain, increasing risks. Regarding efficacy, to deliver effective results, eliminating varicose veins and improve the leg's appearance is essential to control bubble size, to ensure product stability. Small bubbles mean a large active surface area, enhancing interaction with the veins endothelium. This reduces the risks of sclerocoagular formation, which can lead to hyperpigmentation. Plus, bubbles with smaller radius are more stable and ensure better contact with the vein wall. Balance the liquid gas ratio. Adjust the foam's liquid to gas ratio to have wet, regular, or dry foam viscosity to match the vessel diameters. And remember, blood is the enemy of sclerotherapy. Your foam must displace it to achieve good results. Good results start with a good microfoam. Sclerotherapy requires a high-quality product, but mastery of technique is essential. I use Cabrera's technique, proximal sclerotherapy, the use of long catheters, the closed door technique, which employs dorsiflexion during injection to temporarily close leg perforators and prevent foam from entry to the deep venous system. Foams act as a contrast medium in foamography, help to identify venous reflux sources and improve treatment outcomes. This video shows how the echogenicity of stable foam, visible on ultrasound, when is injected, helps identify small varicose veins in the feeds of telangiectasias. By addressing the feed veins, we achieve improved and longer-lasting aesthetic results. This helps us better understand the hemodynamics and decide the appropriate approach to improve treatment outcome. Comparative studies by ECMA on nitrogen effects show that nitrogen-free microfoam produce smaller embolism bubbles compared to air-based foam. Without nitrogen, you can use more volume and improve our results. This study is one more of the studies that compare the characteristics of homemade foams versus industrialized foams, e.g., varicina. Industrialized foams had smaller, more uniform bubbles, less than 500 microns, leading to better stability in the efficacy. Homemade foams containing large bubbles decrease stability. These studies analyzed foam stability and degradation, focusing on the key parameters such as bubble size, distribution, drainage time. The degradation rate, look here, or dwell time refers the duration the foam remains in contact with the vein wall, acting in the endothelium through its active surface. A longer drainage time allows better contact of the sclerosant agent with the endothelium, improve treatment efficacy. Nitrogen-free foam showed lower degradation rates and prolonged sclerotic contact with the endothelium compared to air atmospheric-based foam. Look here, the stress in the vein wall. This study analyzed foam characteristics in sclerotherapy, focusing in its behavior inside veins. Foam stability depends on the gas used. CO2 is less stable but safer. Small, compact bubbles enhance viscosity and effectiveness, displacing blood with minimal mix and deposit surfactants on vein walls. Homemade foams are less cohesive with lower wall stress and greater dilution. The research highlights how gas choice, bubble size, and foam structure impact treatment efficacy. Look like a foam, like in that video, can displace the blood enemy of sclerotherapy. Don't mix with the blood. This is a new machine developed by Juan Cabrera Garcia. I have hands-on experience with this device, a privilege granted through my years of scientific collaboration with Cabrera family. It produces high-quality, ultra-stable foam, nitrogen-free, and they allow, look here, and they allow gas ratio adjustments, including O2 and CO2, tailored for the specific needs of each patient. So you can decide the proportion of gas that you want to use and the structure of the foam, liquid to gas ratio. You can put more or less liquid polydoconal in your mixed foam. Excellent cosmetic results can still be achieved despite vascular concerns about hyperpigmentation, with the use of a good product in the appropriate technique. Another outstanding cosmetic result. Another cosmetic outcome highlight consistent success. Yet another case. This patient had 3 previous surgeries, leading to new vascularization connecting the popliteal fossa, the popliteal vein, to the superficial network, causing new varicosities. Scarring was present in the popliteal fossa. Ultrasound guide 1 is recommended choice for complex recurrence in the popliteal fossa, as Perrin studies demonstrated. The same patient two months later after 6 sessions. And finally, this procedure is ideal for patients with ulcers, as it allows visualization of the veins with ultrasound, enable injections in fibrotic areas that would be difficult with other techniques. This patient underwent 4 surgeries, 2 of which I performed. She had lived with recurrent ulcers for many years. 5 years after the initial foam sclerotherapy treatment, you can see that his skin has improved with no recurrence ulcers. Why I put this here? Sclerotherapy is a phase treatment that enhances patient medical relationships, promoting great adherence to follow-ups. I think that all treatment of varicose veins is for cosmetic reasons. In the end, then, many of my patients, if you have ulcer, if you have great problems, at the end, they ask for cosmetic results. These patients seek not only medical relief, but also cosmetic. Look at her foot. After treatment, she has red nail polish. Foam sclerotherapy is versatile, simple, and well accepted for repeated treatments. Foam technology have enhanced safety, stability, and the patient's outcome. Continuing research and the refinement of techniques will further solidify wholly in treating varicose veins. Muito obrigada.
Thank you so much, Solange. That was a wonderful presentation. I gotta say, I feel incredibly jealous of all of my colleagues who are outside of the US, because we definitely have, we are to some extent restricted as far as what we can do with foam. And I think that absolutely limits, the results that we can get. The fact that we pretty much are limited to creating foam by hand. I think by now we have enough solid evidence to show that that is inadequate, that we can create much better foam using agitators and the Cabrera foamer, for example. And so, believe me, anytime I'm using the Tessari method to create foam on a sclerotherapy session on a daily basis, I'm so jealous of you guys having those great agitators that we know create better foam, whether you're using it alone or in combination with laser, like on the CLaCS technique. I think we have significant limitations, and we need to keep working to try to get some of those agitators and just better ways of creating foam here in the US for us to be able to offer that to our patients and practices.
Okay,
So,
I totally agree.
Right? Yeah, it's really unfortunate. Just for those of you who are not doing this very often, or just new to cosmetic sclerotherapy and using foam for treatments, just understanding the fact that the foam that we create by hand, which is essentially what we do on most of our practices here in the US, is just so limited compared to the quality of foam that is important. So I dream of the day that we get some of those agitators here.
And I think that about the quality of product, technique is very important. And sometimes this feeder's vein, for example, I forget for the medical during the treatment, and because of technique, sometimes they don't have good results with the procedure.
Yeah. So it is obvious that there is such an increase, or it's a surge in demand for aesthetic treatments worldwide. And so how can we balance, how have you both balanced having the medical and the cosmetic aspect of those kinds of treatments for your patients? How do you balance that out? How do you have those conversations when you have someone who maybe comes from cosmetic, but obviously has medical concerns that need to be addressed before? What is that balance? How does that look like in your practices?
I think that meeting patient expectation is crucial. Setting realistic goals from the beginning helps align the expected results with the actual outcomes. Ensure great satisfaction for patients if you do that. When patients understand what's possible in the realistic, they are more likely to be pleased with the results, I think.
Well,
Nara, how about you?
well, it's the the photo documentation is important to bring us this security to tell the patient your vein gone, because most patients that look for us for a cosmetic result have a idea that will have the same percent of disappearance of their veins, and when I show that the technique, the treatment allows a result that is good to the eyes. When we show the photo for the patient, the before picture for the patient, almost time the patient forgot her veins, and when they saw her pictures, oh, this is not my leg. It's not my leg, doctor. It's not my leg. So I think the photo documentation help us so much in this.
Yeah, I agree with that. I think both for medical anesthetics, it is just so important to be able to get those pictures, because I agree with you, Nara, how patients forget. I mean, I see it every day where you have someone who's been living with a very large, one of those large varicose veins, that it's hard for you to believe that someone would forget that they used to have that on their legs, because obviously they've lived with that for years usually. And it happens to me as well. They totally forget. And so having those pictures is, it's not just for you to be able to say that your treatment worked, but for them to be able to understand how we were able to change things, and for them to appreciate that it's absolutely important. Hard to believe that happens, but it does. So photography is absolutely very important for both medical and cosmetic, but especially cosmetic, because that's our goal.
Oh,
So,
Lina,
yep.
let me tell you something about the pictures. Nowadays, it's not only for patients, for us, even for lawyers. And when they say that we didn't do a good treatment, so against they sue us, I guess it's a very good tool to have the pictures of the patients before and after. So not only now we used to be like for cosmetics results, but nowadays we have to fight against that they saw us, or maybe to have a problem with the lawyers and everything.
Yes, absolutely.
Rebecca, I think that is very important at this moment. Emphasize the good pictures. I do documentation photography of my patients too, and it is very important to do well pictures, because it is very interesting for us if the patient is not satisfied at the end. Success measures show patient satisfaction, visible improvement in vein appearance and symptoms reduction, but plus I use questionnaires of quality of life and to patient answer. And like Lina told us, the patient forget how the leg was when the beginning the treatment. It is used.
Yeah. So moving on to a different topic. So and you both mentioned it. We all know that the main complications with treatment of spider veins, telangiectasias, reticular veins, with whatever method, is matting, hyperpigmentation, and those are definitely, in theory, like Nara was saying, they're mild, but they're a big deal when someone is looking for a beautiful aesthetic result. So understanding that those are the two major complications, especially for matting, we know that that usually happens when we have an afferent vein that has not been addressed or that is still patent, correct? So we always, Solange, you showed it on the ultrasound beautifully, as that foam was going a little bit deeper into potentially a reticular vein that couldn't be visible under the naked eye. And Nara, you showed it with the augmented reality. As far as treating it with laser, I think the main thing to realize for anyone doing these types of treatments is that addressing the afferent vein and the efferent vein in whatever way possible is so important for the treatment that just doing small injections of the small telangiectasias that we can see with our naked eyes is usually not enough. We're usually just treating the tip of the iceberg. So one concept that I think is very important. Now, Nara, this question is for you specifically about the CLaCS technique. So from what I was seeing you do on the videos, because my concept of when I use laser transdermal laser to treat these lesions on my patients, I'm usually tracing the vein very closely. I was seeing you kind of do shots at different levels, kind of getting what I assume were the afferent and the efferent vessels. But can you tell me a little bit more about that? I didn't necessarily see you tracing the whole vein, but just doing shots here and there. Can you explain that to me a little bit more?
Yes, because in CLaCS, the aim is to cook the vein. It's not to burn the vein. And also it's important when we have a reticular big one vein, to do shots around the vein. So sometimes I do in left, sometimes I do right, sometimes I do in more close to the skin, sometimes I do more
Superficial?
you know. So this is to cook the vein. And Professor Kazu says always, the laser is not the Brad Pitt, you know, of the CLaCS technique. The Brad Pitt is the sclerotherapy. So it's our experience in sclerotherapy that bring us the good results, and it's important to use in sclerosant that they are good for us. Professor Kazu use glucose because he doesn't use any detergent, you know. But I use foam, and when I use foam with low potency because I live on the beach, you know, and the hyperpigmentation is I think that is better not happen here, because if I have one patient with hyperpigmentation is
It's
very
a disaster.
it's a disaster for my clinic, you know.
By the way,
Yeah.
Nora, I have a question. Should the laser be used before or after sclerotherapy?
So it's a good question, because in CLaCS we use before this sclerosant. We have in the literature descriptions of using the foam before and the laser after, but when we use laser before, we are using directly in the hemoglobin and directly in the target. When we do the sclerosant first, we will not have this target. We'll have foam, liquid, STS, glucose, you know. And when we do the laser first, we use more laser. We get more potency of the laser.
Perfect. And then do you, on the chat, Dr. Ozsvath is asking if you change the concentration of the sclerosant, and I think you mentioned that for darker skin types, like higher Fitzpatrick's, but how about the laser? I think, what's your take on laser settings as far as darker skin types?
Yes, I treat Fitzpatrick until 5, you know, and when I use in higher Fitzpatrick's, I use low fluency. I use a fluency about 40, and I pass more times. I pass 3-4 times, and I am seeing with the augmented reality. I am seeing the vein. I am seeing the vein cooking, you know, and sometimes I do more than 3 times. Low the fluency is important to high Fitzpatrick's. I have so many high Fitzpatrick's here. But the tanning skin, the patient that tainted her skin, this is avoid, you know. It's only the situation that I don't use the laser. And I change the sclerosants. I use protocols 0.5%, and I use 0.5%, and I use glucose. It's the 3 sclerosants that I use in most.
Yeah, I think it's important to clarify. I think, Nara, from your presentation, it's obvious that your laser of preference is at 1064 nanometer and Nd:YAG, which is also mine. For when speaking to other practitioners, obviously there are a lot of other lasers that are good for vascular lesions, but it's important to understand that some of those other ones are actually more superficial lasers that I think are insufficient for veins. Like if you're going to treat under eye veins or cherry red spots on the face and the chest, lesions that are very red, a lot of oxyhemoglobin, very low pressure, you can treat those with that. When you're talking legs and you're talking high pressure, right? And you're talking deeper, larger veins, 1064 is definitely the way to go. But the other, that also makes it ideal because it's a laser that penetrates deeper into the skin. And so it's going to respect the superficial layers where the pigment sits. So it is a safer laser to use, and essentially on all skin types. But yeah, I absolutely agree with being more careful with patients who are tanned, who have higher Fitzpatrick skin types, just for safety. We never want to sacrifice safety.
Yes.
So I absolutely agree with that. So let's switch it over to Solange. I have a question for you. What are your recommendations for compression when you do your treatments with foam sclerotherapy? And actually, Nara, if you can also, after Solange, can give us your thoughts on compression. What's your protocols following cosmetic treatments? Because I think there's a lot of variability and opinions on that.
Okay, I recommend the using 20 to 30 millimeters of mercury compression stocks.
For how long?
Continuous for 24 hours after treatment. For cases with extensive veins and feeders, I advise wearing them for 3 consecutive days. After this period, I suggest wearing stocks only during the day for an additional week, if possible. It depends on the temperature, it depends on the time that patient returns to the clinic. It depends of the possibility of the patient to use compression. But it is like this.
Solange, I have a question for you. How can we ensure high quality cosmetics results in vein treatments? Do you think it's not only the technique? Do you think it's the compression too, or how can we get best results for the patients?
I think it is very important to ensure high quality results. I begin with a thorough assessment of each patient. I use advanced technologies that allow for precise treatment and better visualization of the target veins. Personalized treatment plans, I think, that are essential, as is selecting high-quality products and adjust the volume and the concentration according to the vein diameter. The combination of appropriate techniques and the strategy plan is key to achieve satisfactory outcomes, I think. And we need to study the venous hemodynamics and understand each patient. It is a treatment tailored for each patient.
Thank you, Solange. About the diameter, do you have?
Go ahead, Rebeca. Yeah, that's a question that I had in my mind as well, because where can we stop? Is there a limitation to what we can treat based on size, right? That's where you're going.
Yes, I don't know if you can answer, Nara and Solange, about the diameter that we can treat with each technique, please.
For CLaCS technique, Professor Kazu recommend 3 millimeters is a big vein, you know. Today we are using larger spot size, and how I said before, we cook the vein. So we do the laser in some directions, you know, and it's possible to treat larger veins, because when we are using the sclerotherapy, the synergies permit us to do in bigger veins. But today I am using in all veins that are not connecting with a saphenous vein, you know, because CLaCS, when we are using the CLaCS, we will see that you can use in bigger veins, in veins with 4 or 5 millimeters, because you can change the sclerosant. You can use a sclerosant with a high potency.
Thank you.
Solange, do you have?
Okay. I think that to address, to achieve excellent results in veins with great diameter, it is interesting the hemodynamic. And I do proximal sclerotherapy. So I begin with the feeder of the problems, the proximal part. So I do in sessions. I do first the proximal reflux, a small segment of vein. And they wait 1 or 2 weeks, and you can see that the involution of the veins that are come from this feeder vein. So you will continue the treatment with this and drain the coagulants as soon as possible. If they are so superficial, we don't have cosmetic problems at the end. In patients with great diameter of varicose veins are consent about the situation, because they wait a long time to do treatment. And the interaction with the patient, explain the situation, study individual cases, and planning the one treatment for each patient. I think that is very important to have good results.
Talking about results, I think that even if we're experts and we've been doing for a while, and I know you both are, unfortunately, we do face complications and we do face cases of hyperpigmentation. I mean, it's just part of what we do. So
Yeah.
Can you both share how, like some practical tips, how you deal with hyperpigmentation in your patients, just sort of briefly, because I know there's more questions coming and our time is running short.
I think that to avoid the hyperpigmentation, it is necessary good compression. Compression, it is a problem because patients sometimes don't want to use compression. And to do the drainage of the coagulant, if you have one in the patient, as soon as possible, if the veins is superficial, drain the coagulant. Usually you have a less hyperpigmentation.
As soon as we have, as soon as we can, how many days do you see the patient again?
So, if it depends on the patient, the treatment is tailored for each patient. But if the patient have a big problems, I prefer to be close with him. And sometimes, for example, for big varicose veins, saphenous vein, my protocol is I see the patient once a week after, then 2 weeks after, and then 1 month. And I decide if I do the drainage or not. It depends on the inflammatory process of the coagulant. If it's more, if you are more inflammation in coagulants, and are ready, for example, with pain, you can't drainage. It is you lost your time if you puncture situations like that.
Great. Nara, please.
So the pigmentations will disappear with the time, you know, and is very important. Have a talk with your patient before do the treatment. But when we use the laser with the sclerosant, is a way to avoid this unfortunately complication. And when happens, I explain the patient that is a pigmentation that will disappear, and I used to use hydroquinone, 2%, and hydration. And I bring this patient near for me, and I saw her anytime he was, because I think this empathy, this relationship is the key to treat hyperpigmentation and all complications. I think is the better way.
I definitely agree with that. Having good relationships with your patients, doing lots of educations prior to, and just saying this is part of the process, hyperpigmentation and matting sometimes, and understanding that we know from studies that most of them will clear by a year. It's more like about being patient. But one of the things that I just wanted to add is I personally have had good experiences using broadband light, which is sort of like an advanced type of IPL, using specific wavelengths to be able to break up that hemoglobin or hemosiderin by that point, right? When we have that pigmentation. I've used hydroquinone, but I don't know, I have like mixed results because I personally feel hydroquinone is more for pigmentation coming from melanin and not as much from hemosiderin, but definitely worth using for sure. But yeah, lots of education, lots of hand-holding, and just having great relationships with your patients. They're not going to perceive that necessarily as a complication, but more like part of the process, and lots of reassurance that things will get better over time. Just being patient. I mean, there's only so much that we can do to hurry the body to do what it's supposed to do over time. So yeah. So obviously there's so much variation across the world, right, in how we do things. So I wanted to ask, what is your number one tip for building a successful vein practices?
So, Dr. Solange, could you repeat the question?
Yeah, I just wanted to get one quick tip from each one of you to build a successful vein practice. If there's one tip that you can share with us.
I think that the first one is like to do it. And the second one is tailor the treatment for each patient and become close with them. And do your practice with love. I think at the end, study, and read the researches. And at the end, I think that the things will go well.
Nara.
Yeah, I think it's the relationship by doctor and the patient is the goal. And there is no magic formula. There is no lamp genius. I think it's the relationship. I really think it's the way. Study because medicine is and the technology is changed every day. I think.
I think that you need to have in mind that varicose veins is a chronic disease. So it is very important that the patient understand this.
Yes.
For example, it is very common that patient thinks that the varicose veins returns, that you did your treatment, that you do their treatment, and at the end, 1, 3, 4 years ago, 4 years more, the varicose veins is in their legs again. So it is very important, this relationship is to educate, the education for the patient to understand how is the history, natural history of the disease, and the take with I do programs to maintain the treatment. For example, if you end your treatment and you are very satisfied with your legs, I planned with you when you want to go again to see your legs, if a new varicose vein appears, 1 year, 6 months, it depends on the case. But I think that is very important. The patient know about the natural history of the disease and be close with your clinic, to return and to maintain the relationship.
Well, listen, this is such a great discussion. I think we could keep going on talking about this topic for hours. There's so many questions that we have, but unfortunately, our time has come to an end, and there's a very important webinar happening next. So I just want to thank you both, Dr. Evangelista and Dr. Medeiros, for your incredible insights today, for being here with us, and everyone who's joined the webinar today. I also want to share thank our sponsors, Boston Scientific and BARD, for making this possible. I also want to invite you today, if you're seeing my screen, I want to invite you to participate on our next webinar. Make sure that you get the link, make sure that you follow us through all of the channels of VLU University. It's going to be a very, very important webinar. Women leaders across the world. It's going to be on March 1st at the same time, 10 in the morning, Eastern Standard Time. So make sure that you get the link and that you join us next time.
Thank you, everyone. Have a wonderful day.
Thank
you
so,
very
so
much.
much.
Thank you for joining us. See you on March.
Thank you.
Thank you
Bye,
very
everyone.
much. Thank you very much.
Thank you. Obrigada.
Mhm.